Hello students, we are coming into our final assignment. The last week during this rotation is nursing care plans. And so I wanted to talk a little bit about this final assignment. So you guys have a good idea of what we're looking for. So I know that nursing care plans can sometimes feel like a lot of busy work, and we get so focused on learning the pathophysiology and learning how to do specific tasks that sometimes this feels a little bit disconnected from what we're doing. So I want to talk about why are we doing this. So throughout history, nurses back a long time ago basically were just trained to do tasks. And nurses today have evolved into an essential part of the team. We're expected to have thorough knowledge of pathophysiology, to understand pharmacology, and really be an advocate for the patient in asking about unclear orders or asking the doctor for things that maybe we think the patient might need. And we have a really strong knowledge base to be able to do that. So nursing care plans were actually invented in like the 1930s. It was a public health nursing initiative. And then in the 60s and 70s, when nursing changed from this task-based experience to an actual profession, that nursing care plans grew into what they are now, and they're being used in the hospitals, and every single nursing student has had to write a care plan, and all the students coming behind you has had to write a care plan. There's care plans in every single patient's chart, and it can feel kind of disconnected from what you're doing with the patient. And so even experienced nurses, when you talk to them, might kind of roll their eyes or sigh when you talk about care plans. So I wanted to kind of present this in a more accessible way that feels more connected to what you're doing on the floor. So why do we write these care plans? So it's kind of like the structure of what we do. You know, we can't go out and care for patients however we want to. Like, I can't think, hey, I should do blood pressures every 1 hour, and someone else might think I should do blood pressures every 6 hours. Like, we have to have kind of a structure and a framework for why we do what we do. And this structure should be evidence-based. We should know that we're doing X, Y, and Z for this reason, and we're all consistent with it. So the care plans are the why. It's kind of like what we're doing. Why are we doing what we're doing? How are we getting care for the patient? So why are we taking the vital signs? Why are we checking the fundus? Why is the patient even here in the hospital? We're going to get to that in a second. Why are they here in the hospital? So it's kind of like our structure, our framework. It provides consistency. So that's why we have them. So what exactly is it? So the first thing that the nurse has to ask herself is, why is this patient in the hospital? Because that kind of sometimes seems like a silly question. And when I ask that, I kind of sometimes get these looks like, well, they're having a baby, or they're bleeding, or they had a car accident. I mean, of course they're in the hospital, so we can take care of them. So the answer is, a lot of times, you know, they're in the hospital so we can take care of them. Well, what are we doing to take care of them? What does that mean to take care of them? Why isn't this procedure being done outpatient? Why isn't this being done at home? Why isn't the patient being treated outpatient, just getting a prescription from a pharmacy? Like, we ask ourselves all these questions because patients don't get admitted to the hospital for MD care, right? The doctor may come in and round once a day. They may see the doctor for 10 minutes. If they're, you know, they're on a med surg floor for a while, the doctor kind of comes in and checks the chart and sees how things are doing. The rest of the time the patient's in the hospital, they're being cared for by nurses. They're there for like the nursing care, and also collaborative care from OT and PT and all that other kind of stuff. But so the reason the patient is in the hospital is for the care that you provide as a nurse. And so that's kind of like a big thing. Like, I really want you to kind of think about what that means. You know, they're there for your care. They're not there for the doctor's care. Okay. That's an important part of it, because we're part of a team and we collaborate. But really, the doctors, they could be treating people outpatient. They could be doing all kinds of stuff, but they're not. They're there because they need nursing care and the care that we uniquely provide for our patients, okay? So the care plan is the sum of all the actual and potential nursing diagnoses, right? So, and a nursing diagnosis is something that we have identified as a problem or a potential problem that requires our hospital, that requires our patient to stay in the hospital. So the plan of care is a nursing care that's provided during the hospital stay with the ultimate goal of being discharged. So we're looking at what can we do for them there and what are the barriers to being discharged? What are our goals? That's part of our care plans, So what are the realistic goals that need to be met before the patient can go home? So we're going to stop for just one more second because I really want to go back to the first point on this slide is why is this patient in the hospital? So I know this kind of seems kind of silly sometimes when you ask yourself like, well, why are they here? So we can take care of them. Ask yourself, why isn't the patient at home in their backyard? Why aren't we doing this medical procedure at, the Super Save supermarket for discounted price? I mean, I know it seems kind of like a silly question to ask ourselves, but really that's what we have to ask ourselves when we're planning their care. So why is this patient with a kidney infection in the hospital? Let's use that as an example. So a patient with a kidney infection, they're in the hospital. They don't always have to be in the hospital. Sometimes they can be treated outpatient. So why did the doctor choose to admit them to the hospital? Because they were being admitted for nursing care, for what you guys are doing. So what are you guys doing? You're seeing if the infection's getting worse. Well, how can you tell if an infection's getting worse? Well, we see changes in the vital sign. We see changes in the labs. We'll notify the doctor if we see these changes. Like, that's what we're doing for them in the hospital setting that can't be done necessarily at home unless they have like an outpatient nurse or something. So when you ask yourself, when you're there and you're taking care of your patient, why is this cesarean section patient here in the hospital being cared for and not at home? Well, it seems ridiculous, right? We don't perform cesarean sections on the dining room table. Well, why don't we? I have a really sharp kitchen knife. Why don't I do C-sections at my house? I know that this all is ridiculous, but sometimes, it can be helpful to identify what we're doing when we ask ourselves these kind of ridiculous questions. So we don't do a C-section in our house because there's a high risk for infection. Now, don't get me wrong, my kitchen is super clean. However, I bet if you did a C-section on my kitchen table, you would still probably be at a pretty high risk for infection. There's the bleeding, right? I don't have all the stuff to control the bleeding. If you have surgery, you're going to bleed. So that's really concerning. And wow, I mean, if I did C-sections at my house, how am I going to manage the pain? And what about some of the other potential complications, such as pulmonary embolism and all these other things? We're going to be looking for all of these things. And that is basically what our plan of care is what are we doing to make sure that our patients are okay while they're in the hospital, and what can we do to remove the barriers that are preventing them from leaving? So here's some, now this list is not everything. It's not complete. These are just some examples, okay? But here's some potential sample cesarean nursing diagnosis, right? So some general that could pretty much fit for everybody is anxiety. So every mom that's coming in there, they're probably pretty nervous. It might be their first time having surgery. We're there to help them calm down. It's not just a nice thing to help people calm down. It actually can have an effect on them physically too, to help them, to educate them and help reduce their anxiety. They're at risk for bleeding. They're at risk for constipation afterwards because of the decreased peristalsis from the surgery and because of the pain medication. They're at risk for pain, at risk for infection, sleep deprivation, disturbed sleep pattern, impaired tissue perfusion, knowledge deficit, risk for excess fluid volume, edema, risk for injury. They could fall afterwards when they get up, risk for aspiration. I mean, this list goes on. And you can even get into some more specific ones. You can have people that have diabetes that are having surgery and might have problems with blood glucose levels and things like that. So this is a list of some potential cesarean nursing diagnosis. And you can always pause the video and kind of like look at these and see which ones might fit your patient. Here's some for patients that are antepartum. So our antepartum patients sometimes are there for prolonged rupture of membranes, which is going to put them at risk for infection. Sometimes they're stuck in bed, they're really bored. Sometimes also they're stuck in bed, so they have a higher chance of having like a blood clot. So there's all kinds of potential nursing diagnosis for antepartum patients. And when somebody is giving birth, here are some of the potential diagnosis for giving birth. Now, on a side note, this is not a discussion of whether or not you would have a baby at home or not. Okay, but let's go back to, we're asking ourselves the question, how come this isn't being done in the kitchen, right? Why isn't this potential thing being done at home or out of the hospital or at the shop and save or something like that? Well, even a person that's having a home birth usually has, they're a low risk person, so they have less potential for any of these things. And they usually are also being attended by a skilled professional, like a midwife. So the midwife is the one that is monitoring for all of these potential issues too, So they're still getting the care that they need, just not necessarily in the hospital setting. They're doing it maybe basically like an outpatient setting. So, but let's go back to having a baby in the hospital. When I talk to people about what a potential care plan would be for somebody who's having a baby in the hospital, right? So why are they here? Well, because we want to make sure they're okay. Well, how do we know if they're okay? Well, we're going to check and see if there's bleeding. We're going to check and see if they've gotten an infection because they're GBS positive and they're ruptured. We're going to help them manage their pain. We're going to help to educate them. And one of the things is we want to make sure the baby's okay. So how do we know if the baby's okay when you're in labor and delivery? So we're monitoring. We have this monitor. We can look at the baby's heart rate, right? So every 30 minutes, a nurse is going to assess the baby's heart rate when she's in active labor. And that's one of the ways that we will assess whether or not the baby's okay when a mom is in labor. So that would be risk for impaired tissue perfusion. This is placental perfusion, which is just like a subset of the impaired tissue perfusion. So there's more too, but you can go into there are some samples in your textbook, and then in your nursing diagnosis book too, there's that specific maternal child section. So there's a lot of potentials for these diagnoses that you choose. We usually want you to do two, like at least one psychosocial and two like physical diagnosis. So here's one if you're taking care of a baby for NICU, an infant. There's a lot more than you would think, actually. So this is once again not a complete list, but it's like risk for hypothermia, ineffective breathing pattern, readiness for enhanced breastfeeding, risk for neonatal jaundice, all of those things. So let's put it all together, okay? So we're going to go back to our original question. Why is the patient here? Why isn't a cesarean done in the kitchen? So this picture here, I don't know if any of you guys watch Grey's Anatomy, but one of the physicians decided to do a cesarean section on this person in the dining room on the table, which is totally ridiculous. Anyway, so why isn't cesarean done in the kitchen? Why isn't the cesarean done outpatient? Because we think they'll get an infection. If we did it at home, they might bleed. All of these things drive our nursing care. Okay, so what are we going to do about these things that we might be concerned about? So if we're worried that the patient might be bleeding, and that's our concern, that's what we're watching for. Let's say she came in and her platelets were on the low side and her hemoglobin was low, and she had a history of bleeding before, and maybe she's had a couple babies. So she kind of has all these additional risk factors, and we're thinking that that might be what we want to focus on. Let's say we want to think about her bleeding. So how do we know if she's bleeding? Well, one, we're going to look. I know that these questions kind of seem silly, right? Of course, we're going to look at it, but this is what we're asking for the care plan. We're going to assess the bleeding. We're going to look at it. We're going to assess the fundus and make sure that it's full. firm. We're going to check the pads. What is the time frame that we're going to be checking these? Are we going to check them every hour, 2 hours, 3 hours, 4 hours? Some other things that we can look at when we're trying to tell if somebody is bleeding too much is one of the first signs of someone having had too much blood loss is tachycardia. We're going to see an increase in the heart rate before we're going to see that change in blood pressure with somebody that's been bleeding too much. So that's one of the things that we look at too. So let's look at some potential, like a potential nursing diagnosis for a C-section. So let's look at risk for infection related to cesarean. So on a side note, a risk for nursing diagnosis is not going to have an as evidenced by because it doesn't exist yet. But if you say infection related to cesarean section as evidenced by increased white blood cell count or whatever like that, that wouldn't be a risk for diagnosis. So, you know, you would then have that. So let's say we're going to use risk for infection related to cesarean section. So what do you want to prevent? What do you do if you want to prevent an infection and assess if an infection is present? So what information are we going to need to find out about this patient? So are there additional risk factors? Okay, so did the patient come in and she's GBS positive, or she's been ruptured for a long time, or, you know, any of the things that might potentially, you know, is she immunocompromised? What are some of the risk factors that may elevate it? So we want to know this first. We want to know also what the objective and subjective data are for her. Okay, so what is her white cell count? What do her vital signs look like? What does she say? Is she saying that she's feeling the chills? Is she saying that she's feeling things like that? Those are some of the data sets that we're going to look at. So signs of infection are like elevated temperature, increased heart rate, redness, swelling, chills, foul smelling, exudate, tenderness at the incision or in the uterus. Some of the interventions to prevent infection will also be good hand hygiene, good perineal hygiene, personal hygiene. We can teach the patient how to wash their hands, how to do pericare. So these are all the things that you're going to do to help your patient prevent infection, and then also to assess and see if any infection is possibly present. So now we're going to take this the next step. So risk for infection related to cesarean section. The desired outcome is the patient's going to be free from infection during the 48-hour postoperative time period. Our goals, our patient will be able to demonstrate preventative hand hygiene practices. After each personal care activity, patient will maintain normal vital signs during the 12-hour shift. Patient's incision site will remain free from inflammation by the end of the 12-hour shift. So you want to make sure that these things are clear, concise, measurable, observable, time-limited, realistic. So some potentials are every 4 hours, visualize incision site, assess pain location, and pain level. You're going to obtain vital signs, check fundus every 4 hours for the first 24 hours post-delivery, monitor CBC results, administer antibiotics as ordered, follow standard protocol in providing patient care, teach personal hygiene, and have patient teach back. So those are some potential things that you're going to put in as your interventions. And then you need to also know, why are you doing these interventions? What's the rationale? So if you're checking vital signs, why are you checking vital signs? What are you going to need to know about that? What is the purpose of what you're doing? Okay, and then you want to know what the outcomes were for the intervention. So when you're putting this care plan together, you're going to have your goal, your intervention, your rationale, your outcome. You want to make sure you have all of those together one at a time. So when you're taking care of these patients too, and you're talking about like risk for bleeding, risk for infection, all these other things, when you open your care plan book, there might be like 50 million different things in there that are potential interventions. You're really only going to pick the ones that you can do, right? The ones that you can do, the ones that you will do while you're caring for the patient, and the ones that are applicable, the ones that are personalized for that patient, right? So you don't need 50 million things that you're going to be doing. You just need to pick those few key ones that are important and are going to give you the information that you need. And of course, you need to know why you're doing it. So on a side note, I just want to say, I feel like sometimes when I get work turned in from students, They want to show that the patient has met all their goals because they feel like if the patient hasn't met their goals, then that means that they did something wrong as the care provider, but that's not so. So I just really want to make sure that I clear that up, because every patient that you care for, they may or may not reach those goals, right? You can try to help them to do X, Y, and Z, but some things are going to be out of your control. And if you took care of your patient and you did all your interventions and every single one of those like those goals, you did not meet your outcomes, that doesn't mean that you failed as a nurse or you did anything wrong. It just means that you might need to adjust your goals, and change them, and maybe pick something else because they're not maybe at that place that they need to be. So I just want to kind of like cover that. And the other thing too is every patient, you may not have seen this in your charts when you're going through them yet. You can always ask your nurse if she can show you. But every single solitary patient has a care plan in their chart. I promise you, you can find it. It's part of our like requirements. We need it for like insurance reimbursement and all this other stuff. So every patient has a care plan in their chart. So you can always ask your nurse what is written in the care plan, and you can open that and look at the things that have been chosen and what those potential interventions are. And you can use some of those when you're writing your paper, when you're coming up with it, because you don't need to reinvent the wheel. All the information is there. You guys already know how to take care of these patients. It's just kind of like putting it all together, and then for future classes, you can always kind of use this same theory, this same, the way that you kind of ask yourself, why is the patient here? Why is the patient not at home right now? Why aren't we doing this outpatient? Why aren't we doing this at the doctor's office? Why aren't we doing this at the shop and save? You're going to be doing care plans for every single class that you're in. So when you're taking care of a patient that's had a major trauma and they're in a car accident, well, why didn't we just discharge them from the ER? Why did we keep them? Or if you have a patient there that's been admitted for CHF, like, people live with CHF and they live at home with it. So why did this patient get put in the hospital for CHF? Why are they here? What are our goals? Are we trying to, what are our goals? What do we need to do to be able to get them home and taking care of themselves again? And what are we going to do to help prevent problems, to help to assess if there's problems there? So what is it the nurse is doing? And so that's basically what this is you're going to take all of this patient information, your subjective and objective data. You're going to figure out what your patient's there for, what you're going to be doing for them. You're going to choose those nursing, the nursing diagnosis that goes along with that, and come up with your interventions and why you're doing what you're doing, what those outcomes were. And then you put that all together, and that's your care plan. That's your care plan assignment. So I know sometimes it can kind of feel overwhelming, and some of the language, the way that the books are written that address care plans, and the language isn't helpful sometimes too. So sometimes you have to take a step back and just think to yourself, why are they here? What am I doing for them? And kind of put it into a language that maybe feels more accessible than the way it might be written in some of the books. So, and then as always, if you have any concerns or any questions or anything like that, I'm here. Email me, let me know what I can do to help you and kind of help you put this whole thing together. Okay?